I'd like to ask Dr. Panagiotou to come to the podium. He will tell us a very interesting about a very interesting test which is on the market now. I can say it like that. Pharmacogenetically guided treatment in major depressive disorder. I find this very, very important because I have to say for myself, I have been trying to do something like that the last 40 years. I'm very happy that it happened now in Greece, and we have a test where we can test our patients to see what is their pharmacogenetic profile, and according to this, we can give the correct medication to the correct dose. But I won't say anything more. You will hear everything from Nikos. Thank you very much.
Awesome. Okay. Thank you very much. Good evening, everyone. Initially, I would like to thank the organizing committee for inviting me to give this talk, and also I would like to thank you for staying this late into the day. So today I'm talking about pharmacogenetics and how we apply them in the real world, specifically for the treatment of mental health issues. And in this case, I'm going to speak mainly about depression, but whatever I say, it has to do with other mental disorders such as psychosis or other events. And I'm just going to say I represent iDNA for this talk. So initially, I would like to start by saying that in Greece, at any given moment, it is estimated that maybe 1 million people are suffering from the symptoms of depression. And this number can even be twice as large, but we don't really have specific statistical evidence here in Greece. However, in Europe, we know that there is tens of millions of people suffering from depression, and these are patients that have chronic symptoms and all the side effects by their medications, absences from work, and there's a huge cost associated with this disease. So we need to ask nowadays, is there actually a need for a new approach to treat depressed patients? So I'm going to start by talking about antidepressant effectiveness. We know from a lot of clinical studies, but also from the clinical experience, that antidepressants have a delayed onset of action. 1/3 of patients do not respond during the first few weeks or months, and 2/3 of patients do not achieve remission. This means that the symptomatology doesn't go away. And the mean efficacy of all the treatments or of all the possible antidepressants in the market does not differ. We know that there is a lot of association of the antidepressants with tolerance and safety. So there is aggravation of anxiety, sleep disorders, gastrointestinal adverse events, sexual dysfunction, sedation, emotional blunting, and withdrawal symptoms. So obviously, because of all of these side effects that do happen to a lot of the patients taking the medication, there are issues with treatment adherence. So 42% discontinue their medication in the first month, and up to 70% discontinue in the first 3 months. So it's impossible for these patients that discontinue their treatment to actually achieve response and then remission. And 45% do not take the medication as recommended by the doctors. This means that they do not take the medication every day at the given times, or they miss days. So again, a lot of patients do not respond because of these issues. So yes, there is a need for a new approach. And this new approach is what we call precision medicine in mental health. So I want to paint you a picture of what happens nowadays. So nowadays we use what we call standard of care, or later you will hear me saying TAU, which stands for treatment as usual. So basically, these patients nowadays, they undergo a process. This is a trial and error process. So what this means is that the psychiatrist would prescribe a medication. The patients would be on the medication for a few weeks, maybe a few months, and if they don't respond, they might change to a different medication. And this can happen again and again over several periods of time. And this is why depression can be a chronic disorder. And as you can see here, with the treatment as usual, everyone is getting the same treatment at the same dose. And this is a big reason why these patients don't respond. So what we do and what other people do around the world, and this is a very new field, we use pharmacogenetics to actually guide the treatment options that the physician chooses to prescribe to the patients. So with a pharmacogenetic test, we can actually subcategorize patients in distinct groups depending on how they metabolize drugs. So we can find the normal patients that can metabolize drugs normally, and they will respond to the normal dose, which is normally given. However, we have people that metabolize drugs very rapidly, so they would require a higher drug to achieve response. And then we have what we call intermediate metabolizers. So these are people that require lower doses. Otherwise, they would have a lot of adverse events. And finally, we have people that we call poor metabolizers. These people do not metabolize drugs well at all. So sometimes it might be required that they use a completely alternative medication, probably one that's metabolized by another pathway. So by doing this grouping, we can actually achieve precision medicine, and the psychiatrist or the neurologist, they can prescribe personalized drugs, and they can tailor the dose adjustment so that the patients respond. So what are the benefits of this approach? Initially, this is a personalized therapy, so it's an individualized drug selection and dose adjustment by the psychiatrists. With this way, we can achieve higher safety, so there's a reduction in the side effects because people are now capable of metabolizing the drugs at the right dose. And then the next step is that we are actually improving patient adherence, because these patients that do not develop adverse events as often as in the standard of care, they are much more likely to stay on the treatment for longer periods. So we can achieve speedier therapy, avoid the long periods of trial and error, and finally, we have improved the efficacy of the medication, so we can increase chances of treatment success, and there are higher remission rates. So how does that really look like in the real world? So initially, I'm showing you a clinical study that was done in 2019. So this was a 24-week double-blind randomized study in over 1,000 patients enrolled. And what we compare is the TAU, which is the treatment as usual, the trial and error process I mentioned, and the guided care is when the patients underwent a pharmacogenetic test. The psychiatrists took this into account, and then they prescribed the medication at the right dose depending on the pharmacogenetic test. So for depression, in all of the major categories, we see that the pharmacogenetic guided arm, they had higher symptom improvement and statistically significant higher response and remission rates. This is 8 weeks into the trial. So the pharmacogenetic test actually improved the outcomes in these patients. And I just want to show you that this is a continuous effect. So during the trial, the positive effect of the pharmacogenetic guidance continues to increase up to the 24-week period at the end of the trial. This is an even more recent study. This is a year-long, 52-week, double-blind randomized study, and it's also accompanied with a meta-analysis. This was done in Canada. And at the end of the year, although the patient number was small, we still see higher symptom improvement, higher response rate, and higher remission rates for all the patients that received the pharmacogenetic test at the start of the trial and had their medications personalized. And then there's also the associated meta-analysis with other clinical studies that shows a positive effect after pharmacogenetics. Okay, so this is like the clinical effects, but there is even more real needs for these people that suffer from depression, and we can use qualitative measures to actually see whether the pharmacogenetics have an effect. So we can look at quality of life, so there are tons of metrics, and we know that pharmacogenetics from similar studies, they improve quality of life. Metrics such as reduced absence from work, this is a very important one. And I'm going to talk more later about quality adjusted life here. So basically what this means is that these tests improves the quality of life that people spend without symptoms, so longer time in their lives without disease. And then there's also associated costs with illness. By doing a pharmacogenetic test, we can actually reduce or avoid polypharmacy, so cost reduction. We can reduce failed drug trials, more cost savings, and reduction of clinical response time to treatment. So people get well sooner, so it means more cost savings. This is a study that I want to show you because of these qualitative measures. This was done in 2018, and it was based on a clinical trial, again, of 2018. So what I want you to look at here is that we have two columns. One is for the moderately severe depressed patients, and one is for the severely depressed patients. So the first outcomes that we look at is probability of death from suicides. Yes, these people tend to suicide, unfortunately, so this is a huge cost for society. So when we compare standard of care to the pharmacogenetic guidance, we can see that the guided arm, they have less suicides, and the QALYs, which I just mentioned, these are improved when pharmacogenetic test is involved in the equation. And these numbers are larger for the more severely depressed patients, so the benefits are larger for the more severely depressed category. And then about cost savings, again, this was done in Canada, so this was $2,598 saved in the moderately depressed patients, and close to $6,000 saved per patient at the end of the year for the really severely depressed patients. What we do nowadays in the clinical world is that we can do a pharmacogenetic test and we can provide recommendations. There's a ton of data and evidence that we can actually derive this information from. There's pharmacogenetic databases, pharmacogenetic consortia. Very important nowadays in the US, FDA, Switzerland here in Europe, and Korea, they all have pharmacogenetic associations in the drug labels that the drugs circulate in the market. So the information is there. And recently we even had medical guidelines in the Netherlands, which is really important. And specifically, this was the first guidelines, and they conclude by saying that when genotype information is available, use these, they mean to the psychiatrist or the neurologist, to select the right drug in the right dose for the right patient. So this is now clinical ground, so it's no longer just research and clinical trials, this is into the real world. And this is the most recent meta-analysis. It was done just a few months ago, and it clearly depicts a positive effect of pharmacogenetic guidance, both for remission and for response in depressed patients. So we actually do this here in Greece. We have developed this iDNA PGX-CNS test. This is done very simply. This box over there, it contains two buccal swabs, so we can collect the sample of saliva from the patient. This is sent to the lab, and the pharmacogenetic test is done, and then we give the report to the doctor, and then the doctor, depending on the results, they can pick the right drug, and they can make dose adjustments. And very recently, this test also gained reimbursement status by AOP, the National Healthcare System, so depressed patients can be reimbursed by doing this test. What this test looks at is very common to what other tests that the bibliography I showed you look at. So we look at 24 SNPs in 13 genes. These are associated with metabolism, side effects, or response to the medications. And we give evidence of associations with 30 central nervous system medications. And we look at antipsychotics and antidepressants that are given to patients that suffer from depression, but also other categories as well. And this is continuing updated by the new drug labels that circulate in the market or by new guidelines that come up and be published. Now I want to finish off this talk by giving you some data from Greece. We have actually done this research very recently. We have looked at 3,000 patients, psychiatric patients that we have tested here in Greece. You can see some of the demographics of this population, but I want to jump straight into the facts. So initially we look at the cytochrome P450 genes because these are the genes associated with the metabolism of the most common antidepressants in the Greek market. And these are CYP2D6 and CYP2C19. For the first case, you can see in green, these are the normal metabolizers. So these people will respond well to the normal medication that the psychiatrist would give. However, there's a 30% of intermediate metabolizers. These people will require reduced dose, otherwise they will have side effects. And then we have the poor metabolizers, 4.5%. Again, these people require reduced dose or a completely alternative medication, maybe one other metabolized by the CYP2C19. And then the case is even more complex for the other cytochrome because here we also have ultra-rapid metabolizers and rapid metabolizers. So if these people are given the normal dose, they will never respond because they metabolize it so quickly that they have no effect. So basically these patients, they require higher doses in order to respond. Only 42% are normal metabolizers, and again we have a 23.9% of intermediate and 2.1% of poor metabolizers. So obviously overall by identifying these patients we can actually improve the therapy outcomes. Here is evidence from another gene, FKBP5. This is associated with the response to the antidepressants. So if you are in this group, you are much more likely to respond well to an antidepressant given. However, if you are in this group, you are less likely to respond well. And these patients with the reduced response genotype, they could benefit, for instance, from combinatorial therapy with an antipsychotic as well with an antidepressant. These data, they build up on previous research that we've done and published, and in smaller populations, initially in just 500 people and then 1,387, where we also saw 60% with altered metabolism on the C19 and 38% of patients with altered D6 metabolism. So overall, there is about 70% of the patients, of the psychiatric patients that we have tested here in Greece that presented either moderate or significant gene-drug interactions for a range of CNS drugs. And what this means is that their genotype could influence the metabolism and then the toxicity of these drugs. So personalized drug and dosage selection by the psychiatrist, it would definitely be beneficial to improve the safety profile of the medications and also improve response and remission rates by the patients. This is another study that we've actually asked the patients themselves after they received the pharmacogenetic guidance and the medication by their doctors for depression. And we see high numbers, 96% they managed to respond to the medication, 82% reported no serious side effects, 90% reported change in medication. So what this means is that after they did the pharmacogenetic test, they either switched to a different drug or the psychiatrist changed the dose of the medication they were receiving. And 87% they reported fewer physician visits. And I'm going to close this off. This is the case of Portugal. I talked about costs a little bit, so let's see what happens in Portugal and then here in Greece. So in Portugal, they actually estimated what's the cost of depression for the healthcare system. So the direct cost is about 30 million euros. And this is like medical appointments, drug prescriptions, and hospitalizations. However, there are the indirect costs, which is work productivity losses, absence from work, and suicide. And this was estimated to be just above 1 billion euros for 1 year. So this is a huge economic cost for society. So we actually did a cost-effectiveness analysis here in Greece. To do so, we devised this model where we compare pharmacogenetically guided treatment with treatment as usual. This is a tree diagram. It has all the potential treatment options and also the probabilities of the clinical outcomes. When I say clinical outcomes, I mean response rates, remissions, and suicides. And behind each point of this tree diagram, there is also associated costs of healthcare and medications. And at the end of the tree, there are outcomes and indicators such as quality-adjusted life years. So basically, when you run this tree 5,000 times doing simulations, you get this diagram. So basically, every dot in this diagram is one of these 5,000 simulations of the model that you do. So the more to the right that each simulation shows up, it means that the intervention is more effective than the standard of care. So all of the interventions are on the positive x-axis, so it means that every single simulation is more effective than standard of care. And then on the y-axis, we look at costs. So let's say 0.5% of the interventions are more costly and half are less costly. So all in all, what this actually means is that the pharmacogenetic test, it increases quality-adjusted life years, and there is an association of 55 euros per quality gained. So what this means is that if the healthcare system invests 55 euros per patient, this patient will gain 1 quality-adjusted life year. And this is actually really cost-effective, and the European median, to be acceptable, I think it's 17,000 euros. So when you are only 55 euros, you're good. And this is the map of the pharmacogenetic guidance. We initially get the metabolism profile, higher safety, more appropriate treatment, better adherence, faster response in order to achieve efficacy. And I would like to thank everyone.